Good evening. Today we're going to be talking about tonsillectomy. First, we're talking about indications. They're typically divided into two categories: infectious and obstructive. Infectious could be acute or chronic. Example of acute would be peritonsillar abscess. Example of chronic would be multiple episodes of tonsillitis. Obstructive, you have sleep apnea dysphagia, speech, or childhood snoring. This is a very common procedure done in the ENT field with over 500,000 cases a year. And believe it or not, 50 or 60 years ago, this is even more common procedure as children routinely had their tonsils taken out. A few years ago, the indication for tonsillitis was more than 3 episodes per year, which indicates removal. So comparatively speaking, right now we're actually doing less tonsillectomies than we have done in the past. Here is a typical setup for tonsillectomy. Next, we're going to be talking about the perioperative preparation of our patient. First thing to mention is that this particular procedure happens in the posterior oral pharynx, so it's very stimulating to the patient and also stimulates high gag reflex. Therefore, this procedure typically is done under local anesthesia. Oral ray is used and is taped in the midline down by the chin, allowing maximum access to the surgeon, which will be standing at the head of the bed. Patient is then placed in the rose position, which means that the head is going to be extended with either a shoulder roll or sandbags by the side for its positioning, and tegaderm over the eyes, and finally the head is wrapped with surgical towels. Next, a variety of mouth gag can be used, such as the Crow Davis, Damon, or the MacGyver. Next, anatomic landmarks identified once the surgical field is fully exposed, and local anesthesia is administered both in the peritonsillar space as well as submucosally for hydrodissection. This is a picture of the anatomy we will be seeing. First, we have to identify the tonsillar pillars, the anterior and the posterior pillars. They are the palatoglossus and the palatopharynges, respectively. Also, the space in between is the tonsillar space, and that's where our palatine tonsil is located. The most common type of tonsillectomy perceived is what they call hot, which electrocautery is used, either monopolar or bipolar. Here, the tonsil is grasped by Alice clamp and retracted medially to see the lateral extent of the caspule. Next, dissection with the monopolar is completed in the pericapsular plane. Typically, the setting will be 20 watts and is dissected in a superior to inferior direction. We'll be talking a little bit more specifically about the particular plane and what is left in the patient and what is removed. Once the tonsil is removed, we're going to have the pterygobasilar fascia, superior constrictor muscle, and also the fat, the buccopharyngeal fat left on the lateral aspect of the patient. Here, we have to be careful with the muscle because entering that particular plane can increase bleeding. Also, the exposure of the muscle is responsible for the raw painful surface. The inferior pole contains the vasculature to the tonsils, and using the hot technique really is not much of an alteration to our procedure because electrocautery is adequate in controlling the bleeding afterwards. To increase exposure and access to the field, we could suspend the palate with a flexible catheter through the nose. We want to make sure that there is not too much tension applied because it can cause tissue necrosis. The next tonsillectomy technique we'll be presenting will be the cold technique. Here, a 12 blade will be used inside through the mucosa with medial retraction of the tonsils, and the incision is made in the lateral and a superior direction. Fisher knife, which is a non-cutting instrument, is used to bluntly dissect in the pericapsular plane, freeing the patient from the tonsil. Typically, this dissection is a lot easier in children, also in patients who have not had chronic tonsillitis and pharyngitis because of lack of scar tissue. Once we get down to the inferior pole, we need to be very careful to make sure that we secure the vasculature located here, either through clamping, cutting, and tying it with a suture, or we want to switch over to a monopolar electrocautery to control bleeding. Finally, for hemostasis after the procedure, we want to use a combination of Valsalva and also pressure with tonsil gauze dressing applied to make sure that the field is blood-free in order for safe extubation. Postoperatively, once the tonsil are removed, we want to send that to pathology. And also, we want to be very careful about postoperative bleeding because this area is very rich in terms of the vasculature. The blood supply comes from the external carotid system, the dorsal lingual branch of the lingual artery, tonsil, and the ascending palatine branch of the facial artery, ascending pharyngeal of the external carotid, and finally descending pharyngeal of the maxillary artery. The venous drainage occurs via the internal jugular vein. One thing that we do have to keep in mind is that this procedure relatively is very quick, anywhere between 10 to 20 minutes. However, if it does go longer for whatever reason, it might be good to distend the mouth gag in order to allow better perfusion of the tongue and mouth. Postoperatively, we want to tell our patient to be very cognizant about nutritional intake because it is going to be very sensitive. Typically, we want to recommend popsicles and ice cream for the first couple of days. And here is a picture depiction of what occurs in the first week after surgery. And you'll see the increase in granulation tissue. And as more and more granulation tissue occurs, patients will tolerate more regular diet as well as decreased sensitivity and pain post-operatively. And that concludes the presentation.